I call upon the next speaker, Dr. Rekha, to present a topic on localizing the cause for diplopia, a stepwise approach. She is working as associate professor in Manjeri Medical College.
So good morning all. I'll be talking on localizing the cause of diplopia. So whenever you see a case of diplopia, we have to identify which is a muscle that is involved. The next step will be to identify where is the lesion. So it can be at the supranuclear level to the cranial nucleus, the cranial nerve at various levels, and even at the orbit and at the muscle itself. So we'll see. When a patient comes with abduction deficit, this is a patient with the abduction deficit. So where all can be the lesion. So it can be the most proximal area where an abduction deficit can occur will be at the supranuclear level. So it can be at the frontal eye field. From the frontal eye field, neurons pass on to the contralateral PPRF, from the PPRF to the sixth nerve nucleus. From the sixth nerve nucleus, neurons pass on to the ipsilateral lateral rectus and the contralateral medial rectus through the MLF. So in these areas, that is frontal eye field, PPRF and sixth nerve will usually cause a gaze palsy, and usually there is no diplopia. But as Dr. Sandhya told, if there is an asymmetry, that can also cause a diplopia. Now, nuclear sixth nerve palsy, it causes a ipsilateral horizontal gaze palsy. Along with that, there is associated facial weakness also can occur because of its close association with the facial nerve fibers. Now, fascicle of sixth nerve, from the nucleus, it move on to the important structures like medial lemniscus and corticospinal tract. So, assessment of proprioception and touch, and also look for any contralateral hemiparesis. If this is present along with the sixth nerve palsy, think of the fascicular part. It is also associated with syndromes like Fowley syndrome and Millard-Gupler syndrome. Now, as the sixth nerve leaves the brainstem at the pontomedullary junction, it lies in the CSF space. So here, it can be associated with meningitis. And also, the acoustic neuroma can affect the pontomedullary junction. So these should be considered. Always look for features of meningitis like headache, neck pain, or light and sound sensitivity. Now from here, it ascends along the clivus to enter the cavernous sinus. So here there is a sharp turn towards the to pass through the Dorolus canal. Here it can be affected by the stretch injury in raised ICT, and also petrositis, mastoiditis, and even base of skull fracture can also affect this area. Now from here it enters the cavernous sinus. Cavernous sinus, as you all know, it may be associated with other cranial nerve palsies like 3, 4 and first part of the fifth nerve. And the abducens nerve lies within the cavernous sinus. So it can be associated with the abduction deficit with ipsilateral Horner syndrome because of the sympathetics around the carotid plexus. So abduction deficit with ipsilateral Horner syndrome, you can think of cavernous sinus. Now from here it enters the orbit through the superior orbital fissure. Here the orbital apex syndrome, that is along with the 346 cranial nerve, the optic nerve also can be affected. So if there is 346 cranial nerve along with RAPD or visual acuity is affected, think of orbital apex syndrome. Now that was in short about abduction deficit. Now next a patient coming with adduction deficit. Adduction deficit, which is a muscle involved, that is a medial rectus muscle. It is usually associated with third nerve palsy. So the most proximal area where adduction deficit can occur will be the internuclear ophthalmoplegia, that is MLF. The MLF damage can result in an adduction deficit with contralateral abducting nystagmus. Now, nuclear third nerve palsy, it is usually, there are certain specific features to tell it is a nuclear third nerve palsy, like bilateral third nerve palsy without ptosis, or it can present as unilateral third nerve palsy with contralateral superior rectus weakness, or it can sometimes present as bilateral partial ptosis also, because it is because of the peculiarity of the nucleus, that is superior rectus subnucleus innervates the contralateral superior rectus, and the LPS subnucleus innervates bilateral LPS muscle. Now the fascicular third nerve palsy, here from the nucleus it passes through the red nucleus. Red nucleus, when it passes through the red nucleus, any lesion at the level of red nucleus can present with contralateral tremor. So contralateral tremor with third nerve palsy, think of that is Benedict syndrome. And when it passes through the cerebellar peduncle, it can cause ipsilateral cerebellar ataxia, that is an Nagel syndrome. and it can pass through the cerebral peduncle causing hemiparesis with third nerve palsy, that is a Weber syndrome. Now the cysternal third nerve palsy. Here, the third nerve is closely associated with posterior communicating artery. So aneurysms of the posterior communicating artery will affect the third nerve. It usually presents with acute painful third nerve palsy. So any case presenting as acute painful third nerve palsy, think of the cysternal part of the third nerve, and it usually presents as isolated third nerve palsies. Now, the pupillary fibers, the third nerve palsy can be a pupil sparing or pupil involving. The pupillary fibers are present in the superficial part of the third nerve. So, aneurysms and tumor usually involve the pupil, and conditions like diabetes and hypertension usually presents with as pupil sparing third nerve palsies. Now next, the cavernous sinus, as we just discussed, is causes of multiple cranial nerve palsy, and the orbital part, one thing to remember, it divides into superior and inferior division. The superior division usually supplies the superior rectus and LPS, and inferior division the other muscles. Now a few words about elevation depression deficit. One is supraduction deficit, that is elevation. It is brought about by superior rectus and inferior oblique. Both are supplied by third nerve. And elevation deficit, sometimes it is associated with ptosis. So think of superior division of third nerve that is involved, and the site of lesion will be posterior orbit or the anterior cavernous sinus, and it can be part of incomplete third nerve palsy also. Now infraduction deficit, infraduction is brought about by inferior rectus and superior oblique muscle. It can be a third nerve palsy or a fourth nerve palsy. So a few words about fourth nerve palsy. It exits the midbrain dorsally. These are some peculiarities of the fourth nerve. Exit the midbrain dorsally and innervates the contralateral superior oblique muscle. So it is the most common cause of acute fourth nerve palsy will be trauma. And why it is prone to trauma? It is because of the long course. It is present near the free edge of the tentorian cerebelli, and also trauma can occur the trochlea itself. So if our diplopia is not localizing in any of these areas, then we can think of other causes like giant cell arteritis, head and neck carcinoma sometimes can have a perineural spread, variants of Guillain-Barré syndrome, and even myasthenia gravis. So step-by-step approach is the key for diagnosis. Thank you all for your patience here.
Thank you, Dr. Rekha, for a very beautiful presentation explaining all the anatomy and the localization of all lesions in nutshell.